Hi, this is Professor Meg Dean, and today we're going to be talking about the sensory system, specifically problems with ears and hearing. It's very important that you review just some of the general anatomy and physiology of the ears and hearing in general, how the ears work. There's great information in your textbook, but it would be helpful if you just remember some of those basic terminologies, such as the auricle and the pinna, very important when you're doing your ear exam. Um, knowing whether to pull up or down depending on the age of the person in which you're examining, knowing what you're looking at when you're looking inside the ear, that tympanic membrane, and then of course understanding the internal structures of the ear that really affect balance and hearing. So with assessment, everything in nursing starts with assessment. I've got some pictures for you here. I've also got a web link for you for those of you that are interested. You can access the web link on the slides that I've posted attached to this video recording. Certainly inspection, just your eyes, looking at the ear. Do you see anything abnormal, any drainage, any swelling, any unusual anatomy? You can certainly take a look inside with the otoscope. It does take a little bit of practice to be able to visualize the tympanic membrane. It does take practice. When you take your advanced health assessment course, for those of you that have not already taken it, it would be important for you to really practice with that because it does take time to perfect. And of course, when we talk about pediatrics later on, your technique for assessing a pediatric ear does vary a little bit because of the anatomy. Certainly a gross auditory acuity. Can they hear you? Are they responding appropriately? You can also do a whisper test. Can they hear you when you whisper to them? And then there are the Weber and the Rhine tests. And again, there's a nice YouTube video that you can watch quickly. The Weber test is used by using a tuning fork, as is the Rhine test. And you just place the base of the struck tuning fork on the bridge of the forehead, nose, or on the teeth. In a normal test, there's no lateralization of sound. With unilateral conductive loss, sound lateralizes toward the affected ear. With unilateral sensory neural loss, the sound lateralizes to the normal or better hearing side. With the Rhine test, you're going to place that base of the struck tuning forks. You're going to strike it to kind of get it vibrating on the mastoid bone behind the ear. You can have the patient indicate when the sound is no longer heard. You can move the fork beside the ear and ask if it's now audible. In a normal test, the patient can hear the fork at the ear. And again, there's a nice video link for you if you'd like to learn more about that. But again, you'll have the opportunity to practice this in your advanced health assessment course. So hearing loss, I think that all of us have probably experienced interacting with people who have hearing loss. It's very, very commonly seen in our older population. About 50% of people over the age of 70 do have some degree of hearing loss. There is an increased incident with age. This is a disease process very closely associated with aging. Risk factors include, of course, family history. Family history is kind of sort of the universal risk factor in most things we talk about. Congenital malformations, low birth weight, use of ototoxic medications. Some of the more commonly found ones that you will probably cross paths with in the clinical setting would be like gentamicin, an antibiotic, is commonly given. And because of the ototoxicity, they do something called peaks and troughs with that medication to make sure it's at a therapeutic level and it's not becoming too high, because then, of course, we can have some hearing loss that results. Other medications that can cause hearing problems would be loop diuretics, which are very commonly given, especially to our older population or our younger population who happen to have some type of a cardiac issue. Recurrent ear infections, bacterial meningitis, or chronic exposure to loud noises. So men and women who work in loud industrial factories or areas where there are kind of chronic exposure to loud noises, or our young population maybe who listens to their earbuds turned up way too loud, that can have a long-term effect on hearing. And then perforation of the tympanic membrane. There are different types of hearing loss. Conductive, that's caused by an external or middle ear problem. Sensory neural is a nerve problem. Mixed, where they have a little of this, a little of that, that's really complicating thing. Or there can also be a functional or a psychogenic hearing loss where people just completely tune out and literally do not hear because of a mental health issue. Sometimes you see that in people who are in shock. Manifestations, early symptoms would be tinnitus or a ringing in the ears, an increased inability to hear in a group. So you'll oftentimes notice that people who have difficulty hearing try to isolate someone to speak to rather than speak to someone where there's a lot of extraneous noises or other people talking. And then this is the classic turning up the volume on the TV. So if you maybe go to an older person's home or a grandparent's home and you walk in and the TV is blasting, that's a really good indicator that they're having some difficulty with hearing. That hearing loss can be so gradual that the person affected doesn't even realize that it's happening. And so they don't even realize that the TV is turned up too loud. As that hearing deterioration continues, you may notice that they have issues with speech, fatigue, indifference, social isolation. Just think how frustrating it would be to not be able to hear and engage fully in conversation, or to just kind of constantly asking people to repeat themselves. It just makes for a lot of awkward social interactions. And so you will see some people start to withdraw from social interactions. So guidelines for communicating, we've spoken about this previously in Nursing 101. So I'm not going to go over these, but certainly, just using some common sense, speaking directly to the person in front so that they can see your face, your facial expressions. Those nonverbals are a big part of communication. Even if they're not really good at lip reading, you can discern some of the verbiage coming from the mouth based on the movements of the mouth. Speak into the less impaired ear if they have a good ear, for example. And certainly don't hesitate to use hand gestures or motions. That can really help to communicate your message. Some people like to use a message board or some type of a written communication, which can be very helpful as well. So some conditions of the external ear. Earwax impaction, cerumen impaction. We see this a lot in people who just are genetically predisposed to having very waxy ears. Some people just have waxy ears. They can't help it. We also tend to see it in people who work in high noise level areas, because their ears try to protect themselves from that elevated level of noise and then will produce additional wax. And we also see it in the elderly. So we can remove this cerumen by irrigation, suction, or instrumentation. It kind of looks like a little loop, like a little wire loop on a kind of like on a stick, I guess is the best way to describe it. This can be done at home, certainly, if the individual is skilled enough or patient enough to irrigate their own ears, but oftentimes it is done as just a quick office visit. Foreign bodies. Sometimes people get strange things in their ears, bugs, spiders, small toys, you name it. You'd be surprised at the things people can get stuck in their ears. There are certain things that we don't want to irrigate. That would be insects or vegetables because they'll swell and further impact the ear. So if there is a foreign body in the ear, that really should be professionally removed. Now, what about conditions of the external ear? Look at that picture of that ear. You can just tell by looking at that. So that's that visual inspection, that is a very painful ear. External otitis is oftentimes called swimmer's ear, and maybe some of you have experienced this in childhood or even adulthood. And this is just a very irritating inflammation of the ear that's oftentimes caused by a staph or Pseudomonas, or sometimes from a fungal infection. The reason it's called swimmer's ear is because people who are immersed in water frequently tend to have a higher incidence of developing this external otitis. These clients present with extreme external ear pain. Just touching the ear kind of gets a reaction. That's a very quick way to know that you're dealing with an otitis externa. They may have hearing loss because the swelling of the ear canal can be such that it completely swells closed. You couldn't even get like a Q-tip in there because it's so swollen and irritated. The big thing is we've got to get these patients more comfortable. We've got to reduce the swelling. We've got to treat the infective agent here. So they may need antibiotic drops, maybe a steroid drop, some type of a anti-inflammatory like Tylenol, ibuprofen, something along those lines. There is such a thing called malignant external otitis. That's very rare. And it can kind of go beyond the limitations of the ear and actually get into the tissues surrounding the ear and into the skull, which, as you can well imagine, would be quite dangerous. Now, if you have a patient who presents with external otitis, certainly we want to do those things: manage pain, treat the infection, and reduce the swelling. But there's also some important patient education that goes along with that. We would encourage people to not engage in swimming or get that ear wet, like in the shower or whatever, for about 7 to 10 days, and just kind of let that dry out and rest. Recurrence rate on this is very high, so we want to let people know that even if it starts to feel better, if you're not careful, it could kind of come back with a vengeance. Some things that people can do to kind of reduce the risk or sort of manage the recurrence rate after treatment would be to use earplugs or a swimming cap or cotton balls with a little Vaseline or petroleum jelly on them to sort of prevent that water from sort of sitting on that ear. After the ears have been wet, you can even put a little drop of alcohol in the ear to kind of help act as an astringent and kind of dry that ear up and reduce the risk of recurrence. Now, what about conditions of the middle ear? We could have a tympanic membrane perforation, and those will generally heal on their own, but sometimes do require some type of medical treatment. With acute otitis media, we typically see that in kids. Ear infections in kids are a commonly seen presentation in clinic or even the emergency room setting. They can be bacterial or viral, so whether the practitioner chooses to treat with antibiotics sometimes depends on the child's age and the other presenting symptoms such as fever. Clinical manifestations typically include ear pain, fever, some hearing loss, and just generally not feeling well. Treatment in some situations is antibiotic therapy. Myringotomy or tamponotomy is sometimes also done by the clinician. For serous otitis media, that means that there's fluid behind the ear, and that can be accompanied by the acute otitis media with or without fluid, or it can just be on its own where there's just fluid behind the ear, which can be very annoying. For that, they oftentimes, as you see in this little picture that I've got here, they can have sort of like a feeling of ear fullness, hearing loss because sound is not traveling through that liquid very well, pain due to the pressure. Chronic otitis media, that is a result of recurrent acute otitis media. The chronic infection can cause serious damage to the tympanic membrane, causing some scar tissue to develop there. The ossicle, it involves the mastoid in some cases. Treatment is we just need to prevent acute otitis, treat it aggressively, and swiftly. And again, these kids or adults may end up needing a tympanoplasty, ossiculoplasty, or a mastoidectomy in some cases. So some of the middle ear surgical procedures, the tympanoplasty, as I mentioned, is a reconstruction of the tympanic membrane. An ossiculoplasty is reconstruction of the bones of the middle ear. They'll often use a prosthesis in that surgical procedure. And the mastoidectomy is removal of the diseased bone, which the mastoid process is like kind of just below and behind the ear. They could have a cholesteatoma, and that's where there's a benign tumor or an ingrowth of skin that causes persistently high pressure in the middle ear and can cause some serious hearing loss if it's not managed aggressively. Here's just a quick little picture of the stapedectomy for otosclerosis, if you're interested. Some conditions of the inner ear, some of the disorders that you might hear about would be dizziness. People just have an alteration of space. So, if you've just gotten off a merry-go-round, that's kind of that dizzy feeling that people sometimes feel. Vertigo is the illusion of motion or a spinning sensation. And nystagmus is an involuntary rhythmic movement of the eyes associated with a vestibular dysfunction. And vestibular disorders can affect many, many people. And the big problem is when people, particularly older people who have got maybe some loss in bone density, feel dizzy or have bouts of vertigo, they fall. And when they fall, that certainly can result in some significant injury, namely hip fractures, but also think about those patients who may be on blood thinners and hit their head. There could even be more serious effects from a fall. Other things that you might hear about would be tinnitus, which we already mentioned, labyrinthitis, benign positional vertigo, ototoxicity, or acoustic neuroma. So let's talk about Meniere's disease. This is where you have an abnormal inner ear fluid balance. And anytime you got a fluid balance problem, you got a problem. We've talked a lot about this in other areas of the course. So fluid balance problems equal problems. And in this particular case, it's going to really throw your balance off. It's going to make you feel dizzy and goofy, and it's going to impact safety. So we've got this problem with malabsorption of the endolymphatic sac, or the blockage of the endolymphatic duct. You've got a triad of symptoms: episodic vertigo, tinnitus, and fluctuating sensory neural hearing loss. These patients complain of feeling like a pressure, oftentimes associated with nausea and vomiting. So the treatment, there are a lot of dietary recommendations for this. We've got to keep that sodium to a relatively low level. So some things to consider would be reducing the intake of processed foods, which are oftentimes very high in sodium. Also think about salt, because salt also pulls water. Stay hydrated. Don't overhydrate, but stay hydrated. Eating at regular intervals. Increase the fresh fruits and vegetables, then that will help to decrease some of those processed snacks that again have those hidden sugars and salts. Limit the intake of coffee, tea, and any other drinks or beverages that may have caffeine. Watch MSG, so try to stay away from that because it can also increase the symptoms. Another kind of interesting thing is to watch the intake of potassium. So you can still eat potassium-rich foods, but just in moderation. So some of those potassium-rich foods might be bananas, tomatoes, oranges, etc. And avoid aspirin and aspirin-containing medications because it can increase the tinnitus and the dizziness. There are medications that can be prescribed, antivert, tranquilizers, Antiemetics for the nausea, and diuretics can also be used to help with that fluid balance. In some cases that are not responsive to simple dietary or pharmacological treatment may require surgical management to help get these patients back on track, because it really can be quite debilitating. If you have any questions, I'm all ears. Don't hesitate to reach out to me by email or through the Blackboard course. And I look forward to hearing your questions. Thank you.